No, all right. That's all I got for you today. Well, thank you for coming and waking up early. This breakfast is sponsored by Chitogel. Thank you, Chitogel, for your support here, as well as another company that distributes it. I'm not sure how official that is, but it is. So Medtronic distributes Chitogel, and we appreciate that, or they appreciate that. My name's Greg Davis. Thanks for being here. This is my good friend Mike Sillers, and Professor Wormald is on our screen somewhere. It's about 9:30 Sunday night in Adelaide, and Professor Wormald could not make it. If he did come, hi PJ.
Hey, how you going, Greg?
Hey, good. Hear you loud and clear.
Great.
PJ told me if he came to the States, he would have to quarantine in a guarded government hotel for 2 weeks. So I said, okay, so that's okay. But anyway, it's been great to know PJ for many, many years. He is, in my opinion, one of the most epic sinus instructors. He is truly gifted at teaching what he does, and it's nice to see this product come out from his efforts as well. Professor Wormald's going to kick this off, but I do another push. He writes an amazing book, or authored an amazing book about 3D anatomy of the sinuses and really just a surgical technique. And there's a DVD, or you can download the videos that he narrates, and it's very therapeutic, PJ. I like listening to it from time to time. So anyway, I'm going to pass the microphone off to Professor Wormald.
Thank you, Greg, and good morning to everyone in the USA. Obviously very disappointing with the world as it is currently, not to be able to come over to the USA. This is the most time I've spent in Adelaide without leaving the country or even the state in my entire life. I mean, we've been traveling extensively throughout my career, and having had, 18 months of complete no travel at all has been quite a mind-bending experience. But anyway, it is what it is, and we all get through it, and I'm sure hopefully soon it's all going to start going back to normal. So my brief this morning is about talking about some of the research that we've been doing into Chitogel, and I'm really excited about this research that we're going to present to you today. And I just wanted to start with my disclaimers and disclosures. First of all, the disclaimer is that the contents of the presentation are entirely those of the presenter, and that importantly, from a disclosure point of view, that I'm a shareholder in Chitogel. So the history of Chitogel is quite interesting, and Greg said that I should maybe just touch on it at the beginning of my presentation, just to give you some feedback as to where the whole story of Chitogel started. It started in 2005 when we first had the idea that we really needed a dressing that addressed a lot of the issues that were present at the time. In other words, hemostasis, improving healing with lack of adhesion formation, maintaining osteopatency, and we didn't have anything at that time that could do any of these things. It was almost like we were chasing the Holy Grail. Anyway, we started to research chitosan, and we presented early papers on chitosan from 2006, 2007 onwards. And really interesting to see that within 18 months of us doing that presentation and suggesting that chitosan was a good product to look at, there were other manufacturers that actually had products on the market. And now we even have a whole number of different products like Zerogel, Posicet, Chitozol, NovaShield, all containing chitosan as part of that process. So why did it take so long to get to market for Chitogel when it took 18 months for the other companies to do it? Well, for one thing is we wanted to make sure it worked. And so, I wasn't prepared to stand by anything without knowing that it actually did have a positive benefit at the end of the day. So we did a lot of lab work, and then we did animal studies, and we did a lot of human trials, and we have over 10 peer-reviewed published papers on the use of Chitogel, and quite a significant scientific evidence base for it as well. And a lot of people say to me, well, Chitogel, so what? Because chitosan dressings, they're all the same, they all contain chitosan. Well, that's not actually true, because the chitosan is quite different in some of them. Some of them are N-O-carboxy chitosan, and others are deacetylated chitosan. And, the chitosan is quite different in a lot of the chitosan dressings. And Chitogel has another couple of components which no other chitosan dressings have. And one of them is dextran aldehyde, and the other is glycerol. And these two add significant differences from Chitogel to what the other chitosan dressings have. And I think probably the most important thing about Chitogel is the fact that it's applied differently. Because when we look at the dressings that are currently on the market, they come in a sponge form. So you put them between the middle turbinate and lateral nasal wall, then they absorb moisture from the environment, and then they become a gel. But really, it's where their contact surfaces are that you get the significant activity or the action of the actual products within the dressing. And the problem with a lot of these sponge dressings is that you only get the activity on the contact area, which is the middle turbinate and the lateral nasal wall. Whereas Chitogel, you actually inject it through the sinus ostia into the sinus cavities and line the actual sinus ostia themselves. And all of the raw surfaces that you've operated on actually get the gel in contact with them. And so this is quite different from what you see from a lot of the other. And so this is just a video to show you this difference that you will see. So here we have a patient who's had sinus surgery, complete sphenoethmoidectomy. If you put a typical sponge in, you can see the sponge sits nicely between the middle turbinate and the lateral nasal wall. But if you look above, and you can see that there's really no gel in the frontal sinus ostia, in the frontal sinus itself. Whereas with Chitogel, here we're putting the applicator right onto and into the frontal ostia, and then injecting the gel through the frontal ostia into the floor of the frontal sinus, and then filling the nasal cavity, and then filling the sphenoid sinus and the sphenoid ostium, and then filling the maxillary, and then finally providing that stenting between the middle turbinate and the lateral nasal wall for the product. And so I think that's really a very important difference that we see between all of the different Chitogel containing products. And it's also important that we understand how hemostasis is achieved. And hemostasis is achieved independent of the coagulation factors, because any product that actually looks at coagulation factors for hemostasis also is pro-inflammatory. So any product that has or makes fibrin or thrombin or has thrombin in it stimulates that coagulation cascade enormously. And we know that, for instance, FlowSeal and some of the other products will actually cause significant increase in adhesion formation after surgery. And the way that chitosan works, it actually stimulates platelet aggregation and does not work at all on the coagulation cascade. So therefore, you still need to look for spurters at the end of your surgery. You don't expect the hemostatic ability of the gel to take care of an arterial bleed. And so you really need to make sure that your arterial spurters are taken care of before you apply the Chitogel for a generalized ooze. And Greg's going to really go through the hemostasis aspect of it in his talk in a bit more detail. If we look at the dextran aldehyde, and we can see on the left-hand side is at 3 days and the right-hand side at 5 days. This is a blob of Chitogel placed in a fibroblast growth of fibroblasts on a plate. And you can see the zone of inhibition where the Chitogel inhibits the proliferation of the fibroblasts. And as you can see on day 5, we can see in certain areas, the fibroblasts are then able to bridge that gap. So it takes a 5-day period for that fibroblast to start bridging that gap between the Chitogel and the zone of inhibition. And that's really important. But probably more important is that we don't have any effect on the epithelial cell growth. So when we grow nasal epithelial cells and we put Chitogel in the plate, we have no zone of inhibition. We have no limitation of those growth of those cells. So you get inhibition of fibroblasts, but you don't get inhibition of epithelial cell growth. And what about the glycerol? So the glycerol has a number of different effects, but probably the one that we find the most interesting is that glycerol in Chitogel is at 20%. And you can see that this is these are all Corynebacterium. The C stands for Corynebacterium. So Corynebacterium accolens has improves in terms of it's stimulated by the presence of glycerol, whereas Corynebacterium propinium and Pseudodiphtericum, as well as Staph epidermidis, Staph aureus, and Pseudomonas, are all significantly inhibited by the presence of 20% glycerol. So this is plates that we've grown just with glycerol on its own at a 20% concentration. So it's a really important factor in the healing postoperatively. So these three constituents make up Chitogel. So chitosan, very important for hemostasis. Dextran and aldehyde inhibits fibroblasts. We've also done some antibacterial work. So chitosan on its own is pretty inert from a bacterial point of view. It doesn't have a lot of antibacterial activity, whereas the dextran aldehyde does have quite a significant antibacterial activity. And the glycerol has a significant antibacterial activity, but we're going to go through this. It also promotes healthy bacterial growth. And you could see that with the Corynebacterium accolens, it actually promoted the growth of Corynebacterium accolens in those graphs that I presented to you. So hemostasis, we've published all this. This is all in the literature on how, at 4 minutes, you've got almost complete hemostasis with the Chitogel side versus this is in the same patient, one side receiving Chitogel, one side receiving nothing as a control, and comparing the hemostatic ability of that in a large patient cohort, and that's the summary of that. But as I said, Greg will go through that in a bit more detail in his presentation. We also have published on adhesion rates. So here we have, and all of this work is done where the patient serves as their own control. So surgery on both sides done at the same time. Patient is randomized at the end of surgery after the surgeon doesn't know which side is going to receive the Chitogel until the end of surgery, and then surgery, it's randomized and the Chitogel is then placed. And on the control side, same surgeon, same post-op conditions, about a 15% total adhesion rate, grade 2 and grade 3 equal in terms of the severity. And we see on the Chitogel side that we have a significant reduction, almost 50% reduction in adhesion rates, no grade 3 adhesions, but we still do have the odd grade 1 and grade 2 adhesions present. And so a significant reduction in the overall adhesions with the utilization of Chitogel. And if we look at ostia, so because the Chitogel is placed into the ostia of the sinuses, we have a osteopreservation effect because of the inhibition of the fibroblasts and the absence of fibrin and blood clot that forms as a consequence. So if we look at the maxillary ostia, compare the chitosan site of control and the sphenoid chitosan site of control. But probably the most important one, and the one that we really focus on, is the frontal sinus, because the frontal sinus is critical for us in terms of our success of our surgery in the postoperative period. And again, you can see on the Chitogel side compared to the no treatment side, the comparison between the two in the same patient. What I'm really excited about, and what I really think is a potential game changer for us, is some data that we've got from a recent trial that we've just finished. We did 20 patients, all had significant disease, full house FES, so all have London Mackay scores above 15, so all patients who've got quite significant disease. All had bilateral full house FESs, and the surgeon did not know which side was going to receive the Chitogel until the end of surgery. Obviously, because it's the same patient, the same post-op treatment on both sides, and review at 2, 6, and 12 weeks. And we did a microbiome swab at the time of surgery and at 12 weeks. So just 2 time points where the microbiome surgery was done. And what we did is first of all, we looked at infections, and what became quite apparent was that there was a difference in infection rates between the Chitogel side and the non-Chitogel side. So we defined infection as a moderate to severe mucopurulence with a positive pathogenic swab. So an infection that you would feel as a surgeon managing the patient that you would have to treat. So if you get a little bit of minor mucopurulence, a little bit of a crust here or a scab there, we didn't define that as an infection because you needed both to have a significant amount of mucus or pus or inflammation present with a pathogenic swab. And we showed that over the 3-month period, so at any time point in that 3-month period, over the 3-month period, 77% of the sides that did not receive Chitogel had what was defined as a positive infection. And on the Chitogel side, there were 23%. So a huge difference between the Chitogel side and the non-Chitogel side in terms of the amount of infection present. And when there was infection on the Chitogel side, there was always infection on the other side. So, in some of those cases, they just really had a real bad going infection, and it was on both sides, not just on one side. We never saw a patient that had an infection on the Chitogel side and not an infection on the control side. So we didn't see any patients like that. I wanted to show you a couple of videos because I think the videos speak for themselves in terms of that, of what the outcome is. So here's a patient. This is the control side. We can see quite nicely open sphenoid and maxillaries. Frontal is quite stenosed. On the Chitogel side, however, the frontal is really nicely preserved. And you just see the lack of scar tissue. If you look at 3 months post-op on the control side, you've got quite a significant amount of scar tissue around the frontal ostium. You've got mucopurulence now coming through the ostium. You've got edema in that anterior ethmoid. Sphenoid and maxillary still look good. You clean away the mucopurulence. The ostium is patent, but still infected. Whereas on the Chitogel side, beautifully open ostium, none of that scar tissue formation in that, and the ethmoid, the mucosa just looks healthy. It's just a healthy mucosa. There's no edema. There's quite a difference between the two. If we look at this patient, so I wanted to show the CT of this patient because, as I said, we only know the randomization at the end of the surgical process. On the left-hand side, quite mild disease. So not significantly bad disease, just mild disease on the left-hand side. Whereas we look on the right side, there's very significant disease with double densities in the maxillary sinus. It's quite severe disease on that right side. So this is the surgery on the left-hand side, just measuring the ostia at the end of surgery, just to make sure we've got all our measurements for our ostia. And on the right side, you can see the difference in terms of mucosal disease. So in this patient, we opened up the maxillary sinus and we had all this fungal mucus within the sinus itself. And it was so severe, we felt we needed to do a canine phosphatryphin and put the debrider through the anterior wall just to give us a good and complete clearance of all that disease within that maxillary sinus. So you can see here at the end of surgery, we don't have any bone exposed, but we do have complete clearance of the disease. That's the frontal ostium. So quite a narrow frontal ostium on this, on the very severely diseased side compared to the other side. And on the left side, that was randomized as the control. The right side, which had all the bad disease, was randomized to receive the Chitogel. So nothing on that left-hand side. And on the right side, we placed Chitogel at the end of the surgical procedure. So here we're going to put it into the frontal ostium. And we're going to make sure that we fill the frontal recess, the sphenoid, and most importantly, we put Chitogel into the maxillary sinus itself. So you can remember that severe disease that we saw within that maxillary sinus. And so placing the Chitogel within the sinus to help that healing process in that sinus, I think is a really important part of that process. So good hemostasis after the surgery. And this is the left side. So frontal ostium on the left looks good, nicely open, healthy. But as we get to the sphenoid and the maxillary, we start to see crusting and infection. So here we've got crusting on the left maxillary, and we've got pus and purulence in the sphenoid. So when we look at the Chitogel side at 4 weeks post-op, we can see the frontal ostium really nicely healed, nicely patent, healthy. The ethmoid cavity beautifully healed, very nice and healthy. And the maxillary sinus with all that severe disease and with that significant mucopurulence is also clean and clear without any significant disease within that sinus. So, I think that these videos really do tell a story about the differences between, this is all in the same 20-patient cohort. Left side, frontal ostium nicely patent. This is on the Chitogel side. So Chitogel side looks good at the end of 3 months. no problems with any of the sinuses, all healthy. On the right side, nothing placed at 3 months. We can see very narrowed frontal ostium, scarred right down, edema and infection in the posterior ethmoids and the sphenoid. Even though all those sinuses are patent, edema within that maxillary sinus with infection in that maxillary sinus. And so just the final video that I wanted to show you, but this patient was quite interesting. This was a patient that is now 15 months post-op, and you can see very severe disease on all the sinuses, bilaterally, nasal polyps on both sides, quite significant disease on both sides. So once we'd finished the surgery, we can see the frontal ostium on the left, sphenoid, maxillary on the left. On the right side, a little bit more bloody. So we do have a bit more bleeding on that right side at the end of surgery. Chitogel goes to the left side. So we're going to put it right up against the frontal ostium, inject the Chitogel through that ostium. Make sure that the maxillary and the sphenoid have Chitogel in it as well. And at 15 months, we can see a very nicely healed frontal, maxillary, and sphenoid, ethmoid, all beautifully healed. And the patient tells us that for the last 6 months, she's had intermittent discharge from the right side. So here we have crusting, we have frontal ostium still patent, sphenoid still patent, but we have crusting and ongoing edema, you can see after we remove those crusts compared to the Chitogel side, which is really healthy and clear. So really impressive. And so why are we seeing a difference between the Chitogel side and the non-Chitogel side? If you think about it, same patient, same surgeon, same post-op care, nothing is different between the sides other than the fact that the one side received Chitogel and the other didn't. Otherwise, exactly the same treatment on both sides. And randomization, so we weren't choosing which side to put the Chitogel at the end of it. And all of the post-op videos and scoring is done by independent blinded observers as to what they're done off the videos. They're not done by the surgeon. So interesting. So we think that the reason that we're getting health and less infections on the Chitogel side is because the core microbiome is changing. So if we're looking at the healthy bacteria in the sinuses, we are looking and focusing on 2 bacteria. And this has been as a result of all of the papers that have been published worldwide. Corynebacterium occult and Propinium acnes are really the most significant bacteria. And we know that the Dextran component of Chitogel is significantly antibacterial. So we know that. And it suppresses Staph aureus and Pseudomonas growth. We've published a paper on that in the literature on the effect of the dextran aldehyde. We know that glycerol is significantly antibacterial. So I showed you those graphs of how the glycerol at 20% suppresses Staph aureus and Pseudomonas growth and doesn't inhibit Corynebacterium occult. And when we looked at the microbiome changes, so this is at time 0. So this is on the side that was treated. So remember, everything is randomized, so you don't go left and right. The side that was untreated, so our control side and our treated side. So if we look at the amount of Corynebacterium that we had at the time of surgery on both sides, and then we compare that to this is the control side. So the control side, Corynebacterium, and the Chitogel side. And you can see there's a significant difference in terms of the amount of Corynebacterium on the side that received the Chitogel compared to the side that was a control side. And we think this is one of the reasons why we're getting this significant difference. So P. acnes, if we look at the amount of P. acnes, I don't know why there's a bit of a difference between the control and the, as I said, it was all randomized at the time. But if we look at the effect of Chitogel, so here we get a decrease in P. acnes at the 3-month post-op period, whereas here we get an increase. And if we look at this in figures, Corynebacterium occult in the control side goes up 12%. So that's good because it goes up. But if you look at the Chitogel side, it goes up almost double. It goes 25% up in terms of its prevalence. If you look at the P. acnes, on the control side, it actually goes down. But on the Chitogel side, it goes up. And that's significant because if we look at the effect of these bacteria, and we see that this is Corynebacterium acculensis. And if you look at all of these clinical strains, so all these clinical strains were harvested from healthy sinuses. And what we did is we grew them up and we looked at the clean protein extracts from these Corynebacterium acculensis. We looked at these extracts, and we showed that these extracts actually significantly inhibit the growth of bacteria. So this is the control. This is methylene-sensitive Staph aureus, methylene-resistant Staph aureus, and an ATCC strain of Staph aureus. And you can see significant inhibition of the growth of Staph aureus by the products of Corynebacterium acculensis. So important for us. Here we look at, this is P. acnes, this is the strip here. This white strip is P. acnes. And this is in the absence of glycerol. They've seeded the plate with Staph aureus, all the little white dots of Staph aureus. But if you put glycerol in, you can see the significant zone of inhibition that occurs around the P. acnes. And this is because P. acnes uses glycerol as a food source to convert glycerol to short-chain fatty acids that are really toxic to Staph aureus and to methylene-resistant Staph aureus. So what we're seeing here is that by promoting the healthy microbiome and giving the healthy microbiome a food source, what we are doing is we're inhibiting the growth of the pathogenic bacteria and creating a healthy microbiome. So if we just summarize the data from the study, we got infections on the control side in 77% of our patients, infections on the Chitogel side in 23%, and never did we get an infection on the Chitogel side without having one on the control side. And we think that the mechanism of this difference that we're seeing is because we're significantly changing the microbiome, and that good bacteria produce long-term healthy mucosa. So if we can do something that changes the microbiome in the post-operative period so that we get the development of good bacteria in our sinuses, then we are onto a winner in terms of improving the health and long-term outcomes of our patients. So thanks very much for the opportunity of talking to you today.
Thank you, PJ. We should have some time at the end for some questions. And it just, I kind of thought about it recently. Some of you may be thinking, well, how do I get Chitogel? How do I try it out? And Medtronic does distribute it, if you missed that earlier. So just talk to your Medtronic rep, and that's how you can get this. We're going to switch gears a little bit, and I'm going to chat just for a few minutes about hemostasis. And it's something that, when we do it right, it makes surgery very easy. I do have a disclosure, and that's my disclaimer. All right, so why does the nose bleed? We've all seen this photo. There's a couple blood vessels going to the nose. But truly, I was in China giving some talks and went to the Shenzhen ENT Institute and saw this cadaveric dissection. That is why the nose bleeds. And you see this, and you think, how do we ever operate on the nose and get out of there in one piece? You know, how do we have an exit strategy? And some days, yeah, you're lucky just to get out of the room, but it just amazes me the beautiful anatomy here. And there's a short story about how this injection was done. Rumor is that the person may not have quite been deceased when the injection was performed. True story. So key points for hemostasis. This is just a summary, and then we'll do a little bit of a deeper dive here. Pre-op steroids, very nice. Anesthesia is key with total IV anesthetic, controlled hypotension, reverse Trendelenburg. Vasoconstriction is super important with a greater palatine injection, topical epinephrine, and then obviously the full hemostasis at the end, hot saline irrigations, gentle cautery, and hemostatic agents. And this is what I've given many, many lectures about hemostasis, and this was my kind of shtick at the university. And then I went into private practice a year and a half ago, and life changed dramatically. All of a sudden, like, well, we don't have a medicine pump, so TIVA's out. Certainly do controlled hypotension, that's critical, and 20 degrees reverse T. Sorry, PJ, I don't do a greater palatine injection too often. I just don't need to now. I use a lot of topical epi, and we don't have a saline warmer in my ASC, so I don't do that either. And then God forbid, I really try very, very hard not to use a hemostatic agent because I'm not happy with the results of that. I do it if I have to. I do it if I have to use them to get out of the operating room, but only if needed. So that's kind of where I'm coming from. The literature supports this. Many of our colleagues use prednisone in polyp patients 5 days before surgery. This study backs it up nicely. It's just 30 milligrams once a day for 5 days. Significant decrease in blood loss, shorter operative time, and better visualization. There have been now probably 30 studies about TIVA and showing that it improves our visual field. I chose to pick this study because it was back in the 1990s, and my former chair, Ernie Weimiller, published this, and it shows that it was pretty standard for visual field assessment, pretty equal until about 2 hours out, and that's where the gas anesthetics really started to take effect. And it's interesting, PJ published a study in 2005 in AJR and showed almost exactly the same thing. At about 110 minutes, you see this divergence where the visual field really worsens. So if you can cut out the residents and fellows, you can get your surgery done within 2 hours, and you have a pretty good visual field. And I think that's why private practice sinus surgery may be a little bit better. This is a setup back at the university, and very, very particular about having the mean arterial pressure in the mid-60s. Absolutely critical. And it's always funny because for some reason, the anesthesiologists, they have their monitor and they kind of hide it. They turn it away from you and kind of looking around the corner and trying to see it. And so what I do is display the vital signs on a big monitor. So everybody knows, the anesthesiologist knows I'm going to start harping on him. My scrub tech will start doing it. If he or she sees the map going up, I love it. They'll just say, hey, anesthesiologist, can you get the blood pressure down? I don't even have to say anything anymore. So it is nice, but we don't want to get the map too low as it decreases our middle cerebral artery perfusion. Reverse T, kind of this last study, Amina Ver, one of our good friends from British Columbia, showed that 20 degrees RT is ideal. And a greater palatine injection. So this is PJ's study, and I certainly do this if I know I'm going to have a challenging or bloody field with horrible inflamed polyps or with a coagulopathic patient or someone who can't get off their baby aspirin. And then epinephrine. It's interesting. This study dramatically changed what I do, and it's not a huge change. I changed from Epi 1 to 100,000 to Epi 1 to 200,000. The study showed it was just as effective as a lower concentration, had fewer side effects with less increase in blood pressure and heart rate, and it works. It works just as well. So I encourage you to drop back, and especially when you're in the office and you're doing injections, use this because you're going to have less of an adrenaline rush in that patient. Also buffer it with sodium bicarb, but that's another talk. The topically applied epinephrine works 1 to 1,000, works just as well, but key thing, remember what lidocaine does. And one of my colleagues up in Seattle, he never injects, I always inject, and the PACU nurses swear that my patients wake up in less pain. And I think this is why. I don't think it's a surgical technique. He's a fantastic surgeon. It's important to have some way to protect the patient from topical epi. And so what we do is put 10 half by halves in the little specimen cup. We put 4 cc's of epi 1 to 1,000 in, swirl it with the purple pen that comes in all of our kits. We don't have to go get the fluorescein strip from Optho, and immediately it absorbs all of it, and it's purple. So you're never going to have anything to inject. Hot saline irrigations, another study by Amin. This is beautiful, again, but right about 2 hours out, that's where you see this divergence, where all things are equal until that time point. Many hospitals have these fluid warmers, and it's nice just to crank it up to 120 degrees. And then finally, a little bit of gentle cautery. So I use 8 French suction Bovie on every case. If I'm along the skull base, I'm going to use an endoscopic bipolar. Now, hemostatic agents. I'm not going to put any of these under the bus, but they have their challenges. Yes, they work. They stop bleeding, and they stop those oozing cases. They're not going to stop spurters, I think was a term that PJ used. They're not going to stop spurters, but they will stop that ooze. But they have significant fibrin deposition, crusting, and scar tissue. And this is just a patient that I had to use a hemostatic agent on, and this crusting is really, really annoying. It blocks the sinuses. You have to pull it out. This patient couldn't get off their aspirin. That's why I used it, and obviously they bled a little bit in clinic when I did the post-op debridement. So I started using Chitogel. PJ introduced me to it for the hemostatic properties of it. As he said, it doesn't rely on the patient's coagulation cascade. That's pretty nice. Decreases inflammation. It delays fibroblast migration to your surgical field, and and it fights the bad bugs and not the good bugs. But kind of one thing in our panel yesterday, the frontal sinus panel, and Jim Palmer talked about dressing the frontal recess, and I think that's a term that we need to start using more. How are we dressing the tissue? All of the tissue. And when he said that yesterday, I'm like, well, that's one of these things that Chitogel does. Now, the elephant in the room is you have to mix it ahead of time. You can't take it out of the box and use it right at the end of surgery when you need it. But all of us in this room, every surgeon here wouldn't be here if we could not anticipate something. And those are criteria we look for in our med students who are applying to our residency programs, right? We need people to anticipate. We anticipate all the time. So what I do, usually within the first 10 minutes of a case, I'm knowing that it's going to be a bloody case or not a bloody case. I know if I'm going to want a dressing or not a dressing. I don't usually ask for something until the end. But with this, I say, all right, let's open up the Chitogel, and they mix it up. It takes 20 minutes to really mix it up. You just mix A to B, shake it for 30 seconds, and then you let it sit for up to 6 hours. And that's all you have to do. And then right as I'm about finishing, the scrub tech will mix the two components, AB plus C. The other nice thing is you can add other drugs. This is off-label, but you can add Kenalog to it or any other drug to it if you want. You just drop a little bit less of C. So I found that this last mixing job, if I do it 5 minutes before I need it, it's the right consistency, 5 to 10 minutes. It's not too thick, it's not too thin, and it's kind of that Goldilocks thing. The other thing is you fill the sinuses. PJ showed several great videos of filling the sinus. Can you think of anything else in rhinology where we actually use it to fill the sinuses? It's dressing that traumatized mucosa. Very, very unique. And this is how I do. I always keep the nasal floor patent so the patient can breathe. I do start post-op irrigations, the post-op day 1, 4 times a day. That's my standard. And this is just a classic grade 4 out of 4 nasal polyp case. I'm just going to show a couple little polyps going bye-bye. And once that's done, we're going to fast forward a little bit of time. There's the frontal recess. Again, not bad, not super bloody, but it was quite inflamed in the frontal recess and up into the frontal sinus. So how do we treat that frontal sinus? We can't. This is one of the few things we can put into the frontal sinus to treat that lateral recess of the frontal sinus. So I'm injecting it into the frontal sinus. This is a mid-frontal cell, trying to suck out the blood out of the sphenoid sinus, just so I don't have to do it after the fact. Again, filling the sphenoid sinus and then filling the ethmoid cavity. The middle turbinate there is medialized. In this patient, the maxillary sinus was healthy, so I did not put it in there. As you'll see, the maxillary os right there on the side. And that's it. The nasal floor is wide open. There's no oozing. I'm pretty happy with that. 2 weeks afterwards, this is the debridement. And it almost works so well I can't code a 31237, which is a little frustrating, but fortunately there was a little crust down low, and so I was able to. And again, nothing's perfect, but compared to the crusting and the debris that I saw with other hemostatic agents, I was quite happy. This is just a mucoid material in the sphenoid sinus, just old blood and mucus that was trapped. There's this little crust inferiorly off the cut edge of the middle turbinate, and that came out nice and easy. But the key thing that you'll see shortly is that the frontal recess, even though there's a little bit of edema, it's still nice and patent, especially in a patient with grade 4 out of 4 polyps. So there we are. So that's why I use Chitogel. Now, why I like Chitogel, again, you apply it directly to the sinus. If you have a sinus that's really inflamed, think about that frontal sinus CT scan, the lateral recess. Think about that sphenoid and the maxillary, where you rely a lot on topical irrigations. they can get in there, they help, but again, this is something that you can apply that sticks around for a week or 7 to 10 days. You don't get fibrin deposition, and it really eases your post-op debridement. So that's my talk, and I'm going to pass it off for the next few minutes, 10 minutes, to Dr. Sillers.
Thank you, PJ and Greg, for inviting me to participate. I'm going to share my experience, which is fairly limited, with approximately 10 patients, and with Chitogel. These are my relevant disclosures and disclaimer, which is similar to what you've seen in the previous 2 presentations. So I'll date myself a little bit. You've got removable, non-dissolvable packing. You've got dissolvable materials. And so as I look around the room, I think a few people will appreciate this. I remember vividly in residency getting the new gauze packing, which came in 6-foot lengths. We would cut it in half. 3 feet went on the left side, 3 feet went on the right side. And then when the patients came back and you had to pull that out, it was like the magician with the scarves up his sleeve, it just kept coming. And you were just about guaranteed to see a vasovagal event. And I remember as a resident in my mind making a vow, no one's ever going to do that to me. And because it seemed to be somewhat barbaric. Well, obviously things improved. We moved on to products like Miracell, and then we got smart enough, we put it in a little finger cot so it would be a little bit slipperier when it came out. And then a variety of dissolvable materials came out. And so the ideal packing that we're looking for is something that controls healing, reduces bleeding, prevents adhesions, and this is not an all-inclusive list. And some of these are products that come in a gel form or a liquid form, and maybe your experience has been like mine. You've injected them, and as you've washed it, it's just slowly oozed out down into the nasal cavity and the nasopharynx, and you just wondered, well, how long did that actually stay in contact with anything in the ethmoid cavity? So this is kind of the holy grail that we're looking for. We want something that stops bleeding, that reduces adhesions, and promotes the healing process. And so from some of the data that PJ and that Greg have showed, this Chitogel seems to fall into that category. So this is one of my early cases. As I said, I was contacted by PJ and Greg to try this. It was somewhere in the pandemic. That whole time frame just kind of is a blur for all of us. And then PJ followed up with an email somewhere in November of 2020 saying, hey, how's it going? And I said, actually haven't tried it yet. So as of this year, I've used it in 10 cases. And this is an example of a full house fest. And you can see this is the right side. Here's the left side. Everything is open. Ethmoid, sphenoid in the back. You can see the maxillary sinus is wide open. And so this is a little view from more anteriorly, and then you can see where we filled it with the Chitogel. And so in one of my first cases when I did it, I just watched it for several minutes to see if it was actually going to stay in place. And once I injected it, it didn't move. It was pretty much going to stay there. And here's an example. This is a patient that came back, the same one you just saw a minute ago. 6 days post-op, you can see the right side and the left side. That left middle turbinate has medialized a little bit. But if you look at the debridement here at 6 days, this is on the patient's left side. This is a number 7 suction. One little trick, I use 3mm scopes, and so it's real easy to find a little spot where you can actually slide the scope in, gently medialize that turbinate, and then follow it with your suction. And you can see there's a little residual clot and some Chitogel, but you'll be able to see that the mucosa, I mean, it looks amazingly healthy. You can see the sphenoid back in the back. And as Greg said, it kind of almost makes this not a debridement because you're suctioning maybe some clot, maybe a little bit of retained secretions, but otherwise it's not a heavy debridement. And so this is the opposite side. This is the right side. You see the middle turbinate is a little bit better medialized. You can go straight in, and once again, you can see that the ease with which the clot is suctioned, and you can see the relative health of that mucosa. And this is 6 days post-op, and so that's fairly impressive in a patient that had CRS with polyps. Patients that undergo Lothrop procedures, that's probably where, if you're doing Lothrops like I am, you hate that first visit where you do the debridement because there's lots of crusting. it's uncomfortable for the patient, and you may not actually get the full debridement done because of the discomfort. So this is an example of a patient. You can see where the bone needs to be removed. This patient's had previous surgery, so the decision was made to do the Lothrop procedure. The video I'm going to show you here is actually another patient. This is actually one of PJ's, and it's very truncated, showing you the two sides and harvesting the mucosal graft, which is has been a game changer as far as reducing the stenosis rate in your Lothrop patients. There's the septal window, and then from the opposite side, you can see he's creating an anteriorly, inferiorly based flap in the agonizing region, and that mucosa is preserved, and then the drill out is performed. I'm going to fast forward a little bit in this video if I can and show you where once everything is open, you've got a fair amount of exposed bone, raw surface, and you want to cover that as best you can, and that's the benefit of the mucosal grafts, and then rotating that preserved flap back in place. And then you'll see the application of the Chitogel. I've used a variety of materials out there, chitin-based, some of the implants to support my grafts, and that works okay, but there's still a fair amount of crusting that you'll see at that early post-operative visit. And then you've got the quandary of, do I take the crust out and risk my mucosal grafts, or do I let the crust sit there and perhaps be a bridge or for scar tissue formation? So you can see the application of the Chitogel. Let's go. And so here's the post-op visit at 2 weeks, and you can see some crusting, but that new frontal sinus outflow tract from the modified Lothrop procedure is wide open, and very little debridement needs to be performed at that point. So I've got a few key takeaways, and again, take this with a grain of salt. This is an N of 10, and so I know PJ has a lot more data, but this is just my early experience with this. And I would say the takeaways for me are the ease of application with a malleable application tip. You can actually get this material into every sinus that you've operated on, and you can coat it just like was shown. The viscosity is such that it stays in place, which has not really been my experience with some of the other products that are similar in terms of being a foam or a liquid gel. And for hemostasis, again, when I started using this product, I would put it in and I would sit there and wait and watch. I'd ask anesthesia to give a Valsalva, because what I didn't want to happen is for my patient to get in recovery or to get home and begin to bleed. And so I've really been able to experience good hemostasis with this. And then the simplicity or almost elimination of the debridement in that first post-op. And I think that's really important, because my goal at that first visit is to see every space that I opened. If I did a full house vest, I want to see the sphenoid, I want to see the frontal, and everything in between. And again, with an N of 10, that's been my experience so far. So thank you for your attention.
Can we have Professor Wormald back up on the screen? Any questions in a couple minutes before we're going to break? Yes?
If you do a full house vest, how many packages do you need? One per side? Or?
So the question is, if you do a full house vest, how many packages do you need? Just one. It comes, PJ, correct me, how many cc's? It's at least 10. But
20 cc's.
yeah, so it's it's plenty to fill both sides, which is nice for a cost-effective standpoint. Yes?
You do have a bit of a floppy middle turbinate. How well does it keep it utilized?
So my experience, probably 30 cases now, if the middle turbinate is floppy, this does a wonderful job as a stent. If the middle turbinate is stiff and non-compliant and kind of the kind that tends to spring back lateral, I don't think this alone is enough to give that radial force to keep it medialized. A lot of other techniques to change that in a stiff middle turbinate, relaxing incision and that type of thing. PJ or Mike, any addition to that?
No, I agree entirely. I think if you've got a memory in your middle turbinate, if you've had a septal deviation and that memory's there and the turbinate's stiff, this product is not going to prevent lateralization. So, you really either need to mobilize or suture or do something else with your turbinate.
Yeah.
You mentioned hot water. I think of hot water as one of the vasodilation. How are you using hot water?
Yeah, so the question is regards to the hot water or hot saline irrigation, and does that vasodilate or not? And I've heard many theories over the years. The theory that maybe that's one of the questions I'll ask someday through the pearly gates, but the theory that I tend to buy into is that the nose cools off potentially during surgery, and this heats it up and helps with the clotting cascade. That's what I've done. I don't think it vasodilates as we think, and in fact, when a patient calls now and then with a post-op bleeding more than they like, I'll have them irrigate with hot saline at home, and it always works. So, and there's, so not just ARS study, but there's 2 studies through emergency rooms that show if they do hot saline irrigations, their outcome measure was the need to consult ENT. And it showed a significant reduction in otolaryngology consults from the ER with quote, posterior epistaxis, which just means by definition any bloody nose that they can't stop, right? So I'm a believer. Hot is 49 degrees Celsius, 120 degrees Fahrenheit-ish. Yes, Martin. It's the cost comparison between Chitogel and like Nasivor. I don't know off the top of my head, but Kevin, your rep, will be happy to talk. And it's just like cost for everything. There's a little bit of variability, but it's I own my ASC and I don't mind using it, so it's relatively inexpensive. Yes.
What percent of the cases are you using it in?
Great question. What percent of the cases do I use it in? Probably 10 to 20% right now. It's one of those things, it takes a while to adopt it, and I'm still kind of learning which cases. And PJ, you may use it in 100% of cases. But also...
Yeah, well, I think that it's interesting that if you think about how it changes the health of the sinuses in terms of the microbiome and changing the long-term rate of infections, I think that we would potentially in future be thinking about it even with less severe diseased cases. I mean, at the moment, you find that it's probably used more with patients who've got severe disease than it is in smaller surgeries. But, if you really want to get that mucosa healthy and microbiome restored, then it's something you should think about.
All right, so final housekeeping thing. Thank you very much, Professor Wormald and all of you for attending. The program is, there was an error. So the allergy section, Dr. Sankiewicz, you're asking, is right next door. That starts at 8 o'clock. It's not upstairs on the 5th floor in Waterloo. It's there in Waller, ENF. And the general session will stay here. So PJ and our AV crew, thank you for making this happen from half a world away. I'm amazed still. I don't know why after 100,000 Zoom meetings, but this was fantastic. PJ, good night in Adelaide, and thank you, Chitogel, for sponsoring.
Have a great meeting, and thank you very much for being part of it. And thank you to Mike as well.
Thank you, guys.
That's a wrap.